بسم الله الرحمن الرحيم. إن شاء الله بمحاضرتنا عن الجوينت ديزيز. إن شاء الله يكون presentation قدامكم واضح. We will discuss joint pathology. The term arthritis is used to describe a disease that is affecting both bone ends across a joint and causes narrowing, generally causes narrowing of the joint space between them. This is a normal joint space. This is the left knee joint. This is the articular cortex of the femur, and this is the articular cortex of the tibia. And this is the normal articular cortex, which is smooth. This is the joint line. وهذا اللوسنسي اللي نشوفه on plane radiograph. It is formed by the cartilage lining the joint space and the intra-articular lucent structures such as the menisci and the ligaments. As you can see that the joint space is nearly symmetric. The medial joint space equal in height to the lateral joint space, medial tibiofemoral equal in height to the lateral tibiofemoral joint space, and that the articular cortex is sharp and smooth. On the other hand, this is an example of bilateral knee arthritis. You can see here narrowing of the joint space, and you can see bone changes on each side of the joint. So this is what we mean by arthritis. It is pathology in the space, in the joint space, and in both ends on each side of the joint. The morphologic or the radiologic distribution of arthritis is generally degenerative, destructive, and erosive, according to the radiological pattern. We start by degenerative arthritis. We have osteoarthritis as the prototype. The radiological features will be narrowing of the joint space. It is mostly affecting the weight-bearing joints in the body. And the weight-bearing areas of the joints in the knee will be the medial tibiofemoral joint, and in the hip will be the superior aspect of the articular cortex. Subchondral sclerosis, subchondral cysts, and reactive osteophytes. This is an example of a knee joint involved by OA, and as you can see here that narrowing is on the medial side more significant than on the lateral side. You have narrowing of the joint space, periarticular mild increase in density with formation of periarticular osteophytes, which are these excess bone formation at the margins of the joint. Also another example of OA with periarticular sclerosis evident. لاحظوا فرق بالdensity this side in comparison to this lateral joint space, which is typically spared in osteoarthritis. Osteoarthritis can be a primary or a secondary phenomenon. It can occur in joints normally after late middle age and in old age patients, but it can also develop as a secondary phenomenon to any insult affecting the joint, such as post-traumatic or post-inflammatory arthritis. This is an example of an ankle joint with previous intra-articular fracture and secondary extensive degenerative changes, and this is the contralateral normal side for comparison. Again, this is an example of the normal ankle joint, and this is the ankle joint space, which is preserved, and the bone ends, which are smooth, the bone cortex. Well, this is an example of a joint affected by degenerative arthritis. We can see the loss of the joint space, periarticular sclerosis. This is post-traumatic. Another similar pattern of degenerative arthritis is the neuropathic arthritis. Neuropathic arthritis, the hallmark is bone destruction, the presence of bone fragmentation, dislocations, and the formation of loose bodies. Neuropathic arthritis occur in joints that are affected in conditions associated with neurological damage, for example, or peripheral neuropathy such as in diabetes, or in patients with spinal cord injury or spinal cord pathology. So they will develop desensitization of this area and predispose them to development of this type of arthritis. This is an example of, it's called also Charcot joint, the neuropathic arthritis. It is similar to degenerative arthritis in terms of sclerosis and new bone formation, but this is a disorganized, fragmented bone formation. You can see here sclerosis, fragmentation, and the dislocations. Also, this is an example of a charcot joint, which is another name for neuropathic joint. We see here the joint space changes, the periarticular sclerosis, and the loose bodies and bone fragmentation. Another example, another common site for neuropathic joint is the foot in diabetic patients. We see here a disorganized tarsometatarsal joints with dislocation, increase in the bone density, bone fragmentation, and dislocation also at the level of the tarsophalangeal joints, metatarsophalangeal joints. Now we move to the next pattern of arthritis, which is the destructive arthritis. We start by septic arthritis. This is the most important type of destructive arthritis. Septic arthritis is a condition that needs to be diagnosed clinically. The patient will present with a monoarthritis, which is a painful, tender joint, single joint, associated with inability to move the joint. On examination, the joint will appear hot, tender, and the patient will have systemic features and raised inflammatory markers. We have to have a very high index of suspicion and very low threshold for diagnosis of this condition, because this is a serious condition that we need to consider clinically, and radiology may help us to diagnose the condition. So we say it is typically a monoarthritis. It may affect any joint in the body may be affected, typically with systemic manifestations. Fever and joint tenderness and pain are the hallmarks of septic arthritis. The radiological features of septic arthritis will lag behind the clinical presentation. So most patients with septic arthritis will present initially with normal radiographs. Normal radiography does not exclude the possibility of septic arthritis. So if you have a child, say, presenting with limping and knee pain, and you suspect that this is septic arthritis, you have to suspect septic arthritis or to think about septic arthritis, and you send the patient for X-ray and the X-ray returns normal. This, of course, does not exclude septic arthritis, because typically the radiological changes will be late. When they appear, they will be in the form of narrowing of the joint space, presence of joint fluid, periarticular osteoporosis, which means decreased bone density on each side of the joint, periarticular cortical destruction, which means that you can't trace the cortex on each side of the joint, and soft tissue swelling. Soft tissue swelling is one of the earliest findings that we observe in patients with septic arthritis. This X-ray is showing an example of septic arthritis of the intercarpal and the carpometacarpal joints, basically the carpometacarpal joints. You see here, this is the normal joint. This is the normal joint space. This is essentially as a single joint because it shares a single synovial cavity. So you see here the bone cortex, you can see the joint line. This is the normal state. Look here and you don't see definitely the joint line, and you see blurring on each side of the joint. You don't see the cortical margin because there is bone destruction. So you can also observe the faint loose haziness surrounding the bone from soft tissue inflammatory changes. Septic arthritis is a condition that needs to be diagnosed and treated promptly if we want to avoid the serious consequences of the condition, because it can lead to joint damage. And as we said, any insult to the joint involving the articular cortex will end by secondary degenerative joint disease. This is an example of septic arthritis of the metatarsophalangeal joint, second metatarsophalangeal joint. You see here periarticular osteoporosis, which means lucency or loss of bone density on each side of the joint. This is the normal joint space. and this is the normal bone density. And you see here the diminished bone density on each side of the joint. This is the periarticular osteoporosis. And you see also the lack of definition of the cortex because of cortical destruction. And you see the haziness in the surrounding soft tissues from soft tissue changes accompanying this septic arthritis. So this is a destructive arthritis pattern. It needs to be appropriately treated if we want to prevent the serious consequences. This is an example of a septic arthritis of the right hip joint, which has caused extensive destruction of the acetabular cortex with secondary migration of the femoral head into the acetabulum and medial dislocation of the right femoral head inward, secondary to septic arthritis of the hip. Pathological fracture of the acetabulum has resulted. One of the useful investigations in assessment of septic arthritis is ultrasound. When we suspect septic arthritis, we have to suspect it in any patient presenting with a complaint that is referable to single joint. We don't say that every monoarthritis is a septic arthritis. We have a lot of causes of monoarthritis. It can be reactive, example post-viral. It can be crystal related. It can be inflammatory in nature. But the most important diagnosis not to miss and to keep the top possibility to appropriately exclude is septic arthritis. One of the useful investigations to do is to send the patient for ultrasound. Ultrasound will help us to see if there is joint effusion. Effusion will appear on ultrasound. Whatever joint can be imaged by ultrasound, and it can show the presence of joint effusion. This is an example of a hip joint imaged by ultrasound, and this is the femoral head, this is the femoral neck, this is the joint line, and this is the plane of the iliopsoas muscle. This is the normal joint, and the slit-like hypoechogenic fluid and synovium. What happens with septic arthritis is that we accumulate effusion. The joint will accumulate effusion and will appear as lucency, extended with fluid. Effusion is not pathognomonic or diagnostic of septic arthritis. Again, it can happen in any form of arthritis, such as osteoarthritis, crystal deposition, rheumatoid arthritis, and other inflammatory arthritis. But in the context, in the clinical picture, if the clinical picture suggests septic arthritis and we see effusion, so this can be taken as supportive. Effusion should be aspirated, preferably under ultrasound guide, and the material obtained should be sent for analysis and culture to initiate appropriate antibiotic therapy. Okay, starting by empirical antibiotic treatment, and after culture results, we initiate appropriate antibiotic therapy in order to prevent the serious consequences of septic arthritis on the joint. Also, one of the useful investigations in the assessment of septic arthritis is MRI. MRI is very sensitive in the detection of septic arthritis. It will show us the inflammatory changes in the joint, the presence of effusion, the inflammation and edema in the surrounding tissue planes around the joint, and the inflammation and the changes within the bone, and will help us to see if there is evidence of bone destruction and osteomyelitis accompanying the arthritis. So on T2 weighted image, it will show as an extensive edema in the joint, in the bone ends, and in the surrounding tissues, such as this. And in post-contrast images, the inflamed synovium will enhance avidly. This is an example of a shoulder joint involved by septic arthritis, and this is enhancement of the synovial lining of the joint, and this is enhancement of the subacromial subdeltoid bursa, communicating with the inflamed, infected joint in this patient with septic arthritis. So we have to keep septic arthritis as one of the most important monoarthritis. We depend on the clinical picture and we complete our investigations by performing ultrasound. If needed, MRI is highly sensitive, and keeping in mind that radiology will lag considerably, but we have to be able to identify the typical radiological appearance of septic arthritis as well. Tuberculosis arthritis is also a form of infective arthritis, typically more slowly presenting than patients with septic arthritis. It tends to involve the spine, hip, knee joints. It is characterized by extensive juxta-articular osteoporosis, followed by erosions, and then will progress to loss of joint space. Septic arthritis is characterized by extensive inflammatory changes in the surrounding soft tissues, while in Tibia arthritis, the soft tissue changes in the acute stage is typically normal. Healing will be by varying sclerosis and extensive soft tissue calcification, one of the features of Tibia arthritis. Tibia arthritis is similar to erosive and inflammatory arthritis because an early pathological change is the formation of pannus, which is a hypertrophied synovial tissue eroding the bone, which explains why tuberculosis arthritis may be radiologically very similar to rheumatoid arthritis, and we will come to discuss rheumatoid. The hip and knee are the most commonly affected peripheral joints, as well as the spine. Joint space narrowing and erosions are characteristic of tuberculosis arthritis, which may lead to extensive destruction of the articular cortex. A very important sign is the striking osteoporosis, which may be seen before any destructive changes are visible. And at a later stage, there may be gross disorganization of the joint with calcific debris near the joint. So, to summarize it, tuberculosis arthritis is also an arthritis that will lead to joint space narrowing and erosions, and extensive osteoporosis and extensive cortical destruction. This is a joint involved by tuberculosis arthritis, as we can see here that there is changes of the joint and changes on both ends of the joint. We can see here the gross demineralization and the gross osteoporosis, and will be followed by extensive cortical erosions and even destruction. This is also an example of an elbow involved by tuberculosis arthritis, and we see here the gross demineralization and the involvement by erosions. Basically similar to septic arthritis, but with appearance of gross osteoporosis and demineralization. We can put septic arthritis as a possible differential. It is also similar to rheumatoid arthritis if it presented with erosion-like appearance. But the clinical progression is somewhat different because clinically it tends to present in a more slow presentation than septic arthritis, with systemic features, with fever, with ill health, and with rapid rise of inflammatory markers. A specific type of arthritis, whether septic or tuberculous, is the spondylodiscitis, which is an arthritis that is centered on the intervertebral disc. You know that the intervertebral disc is a form of fibrous joint. This is arthritis involving this type of joint, causing destruction of end plates of the vertebral bone. The MRI will show enhancement of the involved tissue and may show paraspinal collection. So on X-ray, we see narrowing of the disc space, which is non-specific. It can be seen even in degenerative disc disease, but combined with the clinical picture, it will help us to define the involved disc space. On T1, we will see that the adjoining edema of the end plate, this is edema seen on T1 as hypointense tissue, and on T2, it will appear as area of brightness, and on contrast enhancement, it will extensively enhance. This is edema. This is the involved disc, with edema appearing hypointense on T1 and hyperintense on T2. And after giving contrast, there will be extensive enhancement of the involved bone and the disc space, with the possibility of formation of paraspinal collections and abscesses. Now we move to the next topic, which is erosive arthritis. Erosive arthritis, generally it is caused either by inflammatory causes such as rheumatoid arthritis, juvenile rheumatoid, psoriasis, ankylosing spondylitis, inflammatory bowel disease. All these are called seronegative arthritis. The rheumatoid is rheumatoid, juvenile rheumatoid. The baqi, psoriasis, ankylosing, inflammatory, we call them seronegative. And the crystal depositions such as gout also will give us erosions. This is an example of a normal joint line, and the sharp, clear bone on each side of the joint, normal articular cortex. And this is example of erosion, and this is what we mean by erosion. Defect in the bone. We start by rheumatoid arthritis. It is a polyarthritis with multiple joints affected. Generally, it is a systemic disease that is generally bilaterally symmetric. It has a predilection for the small joints more than the large joints. We mean small joints of the hands and feet more than the larger joints such as the knee, ankle, hip, shoulder. The pathology behind it is synovial hypertrophy leading to the formation of pannus, which is have a tumor-like effect on the underlying bone, causing this erosion or defect in the bone. The radiological features will be joint space narrowing that is homogeneous, not just the weight-bearing area, periarticular osteopenia or periarticular osteoporosis, juxta-articular erosions, soft tissue swelling, and tendency to involve the small joints of the hands and feet. It can also involve the axial skeleton and may result in fatal atlanto-occipital disease. This is an example of rheumatoid arthritis erosions involving the small joints of the hand. And this is the end stage of rheumatoid arthritis. The problem, it is a crippling disease with deformities. These are the classical deformities of rheumatoid arthritis with subluxation, and we call this ulnar deviation of the metacarpophalangeal and interphalangeal joints. And you notice the extensive changes in the carpus and in the radiocarpal joints with loss of joint space and subluxations and collapse of the bone. Rheumatoid arthritis may involve any joint in the body, any synovial joint in the body. In the larger joints, such as the femur and the knee, it does not necessarily cause erosion, may only cause severe narrowing. Notice that it is homogeneous, not just affecting the weight-bearing portion of the joint, and with periarticular osteoporosis and not necessarily visible erosions. This is also an example of rheumatoid arthritis involving the knee joint with extensive joint space narrowing that is homogeneous with periarticular osteoporosis. As we said, it can involve the joints in the spine, synovial joints in the spine with secondary synovial hypertrophy, which is very well shown by MRI. Synovial hypertrophy seen as a mass-like lesion. On X-ray, it will be seen as widening of the atlantodental interval. If it is affecting this joint, it will be seen as widening, which implies the presence of atlantoaxial instability. Of course, this can lead to laxity and endanger the cord. You can see here this mass of hypertrophied synovial tissue, and it may compress the spinal cord within this region and may lead to serious neurological consequences. Similar to rheumatoid arthritis is the condition juvenile rheumatoid arthritis, and its whole spectrum from Still's disease, juvenile chronic polyarthritis. It has multiple subtypes. You will take it in detail in rheumatology. It shows many features similar to rheumatoid arthritis, but erosions generally are less prominent. Knee, ankle, and wrist are the joints most commonly affected. The specific thing related to juvenile rheumatoid, because it affects pediatric patients, is that the hyperemia from the inflammation will cause epiphyseal enlargement and the premature fusion. So it affects the growth of the child. So this is a child affected by juvenile rheumatoid arthritis. Because of inflammation, we notice that there is enlargement. We have bulky metaphyses, epiphyses, enlargement and squaring of the bone with secondary deformities. We move on to the next inflammatory arthritis. As we said, we have rheumatoid, juvenile rheumatoid, and we have the seronegative arthritis, which includes psoriasis, Reiter's, and inflammatory bowel disease, as well as ankylosing spondylitis. Psoriasis, similar to rheumatoid, but it tends to affect predominantly the terminal interphalangeal joints, which are relatively spared in rheumatoid arthritis. Rheumatoid has more proximal predilection for the metacarpophalangeal and the proximal interphalangeal joint, while psoriasis favor the distal interphalangeal joint and to less extent the other more proximal joints. It will also cause joint space narrowing and bone destruction, erosions, which will lead to bone destruction and deformities, but with little periarticular osteoporosis. Of course, the patient will have a background of psoriasis and the typical skin lesions of psoriasis, but sometimes, rarely, the arthritis may precede the changes, the skin changes. We notice the predilection for the distal joints by loss of bone, by subluxation, dislocation in this end stage, psoriatic arthritis. And one of the characteristic features of psoriatic arthritis is the preserved bone density and sometimes even somewhat increased bone density, and the new bone formation, periosteal reaction, will happen on the edges of the involved bone. And the characteristic bone loss that will happen, we have a bone loss such as, this is akin to a sharpened pencil, so it is called pencil in cup deformities of psoriatic arthritis. You notice this is similar to the pencil and it's similar to the cup of the pencil. It's called pencil in cup deformities or licked candy stick appearance that is suggestive of psoriatic arthritis. In the spine, seronegative arthritis have tendencies to involve the sacroiliac joint and the interspinous ligaments. So in psoriasis, it will build up a tissue, an ossified tissue, fusing the vertebral bodies. These are called syndesmophytes. So we have syndesmophyte formation. This is part of their new bone formation abilities, and in the sacroiliac joint, they will form a sacroiliitis. In psoriatic, the sacroiliitis is typically asymmetric, involving one joint more than the other. You notice here the preserved and the well-delineated joint line of the left sacroiliac joint, and here you see the widened joint and the blurring of the joint space and the sclerosis that is noted on the iliac side of this patient with psoriatic arthritis with small bone erosions. So this is a joint involved by psoriatic arthritis. You can say that this is sacroiliitis. This is an asymmetric sacroiliitis. One of the other pathologies, such as ankylosing spondylitis. Ankylosing is a condition that is affecting the sacroiliac joint. It has tendency to cause bilateral symmetrical sacroiliitis, while in psoriatic arthritis, it has a tendency for unilateral disease or asymmetric disease. We said that erosive arthritis can be caused by inflammatory conditions such as rheumatoid arthritis and seronegative arthritis, but it can also be caused by non-inflammatory crystal-related arthropathy such as gout. Gout is crystal deposition arthropathy, usually affecting the small joints, typically the first tarsometatarsal joint, podagra, also small joints of the hands and feet. It is characterized by periarticular tophi, which are soft tissue collections of crystals. So gout is a deposition arthropathy of crystals that will cause the changes of erosions that we see, similar to rheumatoid. But the difference is that there is a relatively lack of joint space narrowing. Tophi, we can see tophi that are soft tissue nodules in periarticular locations. The erosions in gout are marginal and characteristically punched out in appearance. This is an example of gouty arthritis involving the foot. You notice that there is relatively preserved joint space, and you have this punched out, okay, or like a beaten and eaten, bite-like appearance, missing portion of bone that is typically somewhat away from the joint space. This is also an example of gout, and you notice the relative preservation of the joint space and this erosion happening at a distance from the joint line, and this formation of soft tissue nodule that is characteristic of tophus. This is also an example of tophi seen in this patient with gout. Soft tissue density, periarticular in location that are characteristic for gout. We have similar to gout, the condition pseudogout, which is also a crystal deposition arthritis, but radiologically it is similar clinically, may be similar clinically, but radiologically it is distinct. Pseudogout is related to the deposition of CPPD crystals. CPPD crystals deposited in the joints, giving rise to chondrocalcinosis, which is a descriptive term for calcification occurring in the articular cartilage. The knee is the most frequently affected joint. It can lead to calcification in the menisci as well as in the articular cartilage. CPPD disease may give rise to an arthritis that is clinically simulating gout, and hence the alternative name is pseudogout. You notice in this X-ray, you have this is the joint line, and you notice the faint increase in density within the joint line, suggestive of cartilage calcification. So this is the way we observe calcification in CPPD. It is faint lucency, faint opacities within the joint line, suggestive of calcifications. This is also an example of a joint involved by CPPD with characteristic chondrocalcinosis. And this is also another example of faint, hazy calcification seen in the joint of this wrist in patient with pseudogout. The reason why it is called pseudogout that it has clinical presentation similar to gout, and it is also related to crystal deposition, but the radiological changes are somewhat different, and the hallmark being the presence of calcification within the cartilage. We move on now to an entity, few entities that will mimic arthritis, not exactly arthritis, but they mimic arthritis by being pathology around the joint, which is a vascular necrosis. Vascular necrosis is not really an arthritis, because as we said, arthritis is something that affects the joint space and the bone on each side of the joint. On the other hand, a vascular necrosis is a pathology that is affecting the bone in subarticular location. It commonly affects the intra-articular portion of the bone. It is bone damage, dead bone, that is seen just underneath the joint line. This is an example of a vascular necrosis of the femur, of the femoral head. Causes of avascular necrosis is steroid therapy, collagen vascular disease, sickle cell disease, exposure to high pressure environments such as deep sea divers, fractures which will result, this is a very important cause, fractures which result in interruption of the blood supply, commonly seen in subcapital fractures of the femoral neck, and scaphoid waist fractures. So this is an example of a scaphoid waist. This is the scaphoid. This is a scaphoid waist fracture that has resulted in a vascular necrosis of the proximal fragment. And what we will see in a vascular necrosis, the X-ray will show us increased radiodensity of the subchondral bone. As you can see here, there is sclerosis, increased density. This is one of the hallmarks. Irregularity of the articular contour of the bone, and even fragmentation. So you notice that the bone is no longer very spherical, starts to have some flattening of the contour of the bone. And joint space is usually preserved, as we said, because really it's not really an arthritis, but it is involvement of the bone adjacent to joint. So joint space is generally preserved unless there is development of superimposed OA, as we said that OA will be superimposed on any type of joint pathology. This is an example of a vascular necrosis of the femoral head, seen as an area of patchy sclerosis involving the left femoral head. And the end stage of a vascular necrosis is the formation of secondary degenerative bone disease with joint space narrowing and osteophyte formation, and the resultant impairment of function. MRI, a vascular necrosis can be diagnosed radiologically, but MRI is the modality of choice for early diagnosis of the condition. It will show the early marrow abnormality seen within the femoral head. Will be seen as an area of loss of the normal marrow pattern in the femoral head and the formation of the line, subchondral lines that are seen in patients with a vascular necrosis. A vascular necrosis can affect the adult skeleton. It can also affect the pediatric skeleton, but we have a different name for it. This time we don't call it just a vascular necrosis. In the hip joint, it is involvement of the epiphyses by devitalization, or a vascular necrosis is termed Perthes disease. So Perthes disease, we notice here a typical example of Perthes disease. We see here that this is the epiphysis of the right femur. It is flattened, it is dense, while the other epiphysis shows normal contour and normal height. Perthes disease is a vascular necrosis of the femoral head in children. The early change is increased density, and then it will be followed by flattening of the epiphyses, which progress later to collapse and fragmentation, with resultant widening of the joint space. This is widening of the joint space in comparison to the other side, widening of the growth plate due to collapse of bone. And with healing, the femur will reform and it will appear grossly flattened. A vascular necrosis can affect various, it is called osteochondritis when it is affecting the epiphyseal part. It can affect various bones in the body. Involvement of the metatarsal, second metatarsal is called Freiberg disease. It is a vascular necrosis of metatarsal head, and notice the flattening and the fragmentation, the increase in bone density. It can affect the navicular bone. It is called Kohler disease. It is a vascular necrosis of the navicular in children. It can affect Kienbock disease, which is a vascular necrosis of the lunate. Again, in every bone, notice that you have increase in density and increase in sclerosis and increased density with flattening and fragmentation of bone. هنا نكون وصلنا إن شاء الله إلى نهاية محاضرتنا. إن شاء الله هذا كان توك مساعد لكم حتى تقدرون تفهمون المادة توصلكم بسبرات فايل إن شاء الله. تقدرون كذلك تستمعون للريكوردينج of the lecture. والفول سكوب of the lecture راح ينزل لكم إن شاء الله على شكل وورد فايل. وبالتوفيق إن شاء الله.
شكرا جزيلا دكتورة.
أهلا بكم.